because you see, continue, I guess I'll continue. This is from 1860 to 2010. And you see that the distribution of our counties, our parishes that are the least, have the worst health outcomes has hardly changed. I mean, that is something that should shock and motivate everybody in this room. Next. Okay, so I'm not going to get into all this because this is a whole different discussion, but health factors are the determinants that result in health outcomes, and you'll see that those maps correspond. Full health, and good health or bad health, and the outcomes. Next. So now I'm going to talk about what I was supposed to talk about, which are pandemics. And I borrowed this slide from Dr. Kavanaugh, changed it a little bit, but pandemics are not new. They just don't happen very often. So those like balls there are the number of people, the millions of people who were killed or died from those. And you see Spanish flu right there, 50 million people. And that was a significant part of the population at that time. And then if you go all the way to the right, you'll see we're worldwide about 6 million. That's probably grossly underestimated. It's probably closer to 10. But it puts us between the third plague and the Antonine plague, which those were historical events. Next. And that's the culprit this time around. Obviously, you've all seen this before. Next. And for the non-technical people if one person's infected. And if I make any mistakes, I have a state epidemiologist here to correct me, Dr. Sokol. So you just pipe up if I say anything that's not factual. So this thing that came out of Wuhan was estimated to have this R0 of 2.4 to 2.6, okay? So with each iteration of this seemed to get worse and worse. And so your Delta was 5 to 8, and your Omicron was estimated around 16. So the infectiousness of this went from bad to worse. There were other things that changed too, but that's pretty shocking. And it's one of the reasons why we saw one wave after another wave after another wave. Next. And those are the waves. This is from our LDH people. And you'll see there's actually been 5. And, 1, 2, 3, the 4th one was Delta. And then, of course, we had Omicron. And you can see this is going way down. So everybody should be.
You're frozen.
I'm frozen.
I can hear you, but there you go.
Okay, yeah, I have this problem in my office too. I think I'm not sure what's related to. Okay, so these data came in, and you'll recognize them, you folks in the audience, and updated there. And I need to minimize my little screenshot thing here or move it around somewhere so I can get out. Okay.
On the left on the top.
Yeah, I just want I just want to see. You'll see there are your 5 waves, and on the bottom you'll see the arrows. You don't see them very well here. I'm not quite sure why, but those are the racial distributions of each one of those waves. And so on the very first wave, the surge number 1, the biggest column there is black. You can't read the black and white because it's really small. But you see that dropped down, and there was a simultaneous decrease of from a black pandemic to a not so black pandemic, and mostly white. Now remember, the African-American population of Louisiana is about 35%. Varies hugely from parish to parish, but that's about it. So it's about 1/3 of the total population. So this pandemic changed its racial composition from the beginning to right now. Next. Gender is not such a big deal, though the higher bar each time was women, and the second bar was men. Next. And this was age groups. And you see those bar things don't look the same, because right in the beginning, remember when we had more blacks than whites infected in Louisiana, it was mostly older people. But we didn't have vaccines at that time. It was poorly understood. The mitigation measures were being implemented, but it's not. So, but you'll see that it changed, because that first wave, this was mostly an older population. As you go on, the youth part of it, which is the middle part, that's 1829, is now the predominant. So it shifted from a older black female pandemic into a younger white pandemic. Next. And those are the deaths by age group. So who died? Every single time it was people over 70. So these are people that had other underlying conditions and all that. So the mortality burden of this was largely assumed by the older population. But remember, the older population is also the ones that got vaccinated, and we'll look at that too, because that changed remarkably. Next. So this is deaths by race and total. And the population is only 35% African American. So if it were absolutely according to population, there would be a third and two-thirds. It would look like always be a third. And you'll see clearly that it's been larger than a third, except probably the third forced surge. But that was changing too. So, and why do people die? Well, if you're unhealthy to begin with, and you add another challenge, then your risks of death increases. And so an unhealthier population will result in more morbidity. Next. Deaths by gender. You'll see, remember the caseloads were more women than men, but the second column is men. So in the first, second, third, fourth surges, it was always more men than women. Who was more vaccinated, men or women? Women. Okay. Shifts. Next. And these were kindly provided by my friends from ID Epi, Dr. Sokol and Kurt Yang. And you'll see that the blacks have been tested at higher rates than whites during this whole thing. And part of it's availability, part of it's where the testing occurred, part of it's because the huge amount of the population is in South, in New Orleans and stuff where they have high population numbers. And so for the whole state, the test volume by race was higher in blacks and white consistently. Next. And this is percent positivity by race. And you'll see the big brown arrow, that's African American, black. And that was a big peak. But that was mostly because it was in New Orleans and a huge population, and it was extending out. And so the positivity rates were enormous there. And then they sort of equaled out. Not really. The whites always had a higher positivity than blacks when you're looking at it statewide. Next. Cases by month and by race. It was kind of parallel, sort of. But when you get down to the end, there is a kind of substantial difference, and it's still, there was more black than white. Next. And it was attributed mostly to test volume. How am I doing on time? I'm good. Okay. So this is cases by race by region. And, for those of you who can't see any of that thing on the bottom, there are three regions with lower populations, and that's 5 and 6 and 8. 5 is Lake Charles, 6 is us, Central Louisiana, and 8 is up there in the Monroe area. And the cases by race vary, and the regions vary by their demographic distribution. And so you'll see that region 1 had a higher percentage of cases and all that. But it should generally be about a third. Next. This is racial gaps in the whole United States. And you'll see that the population that really had that took it in the shorts nationally was Hispanic. That's the brown line on the top. And so there were significant difference. And then, of course, Native Americans, Alaskan natives. But the black and white trends are, kind of the same. And they say narrowed among white, black, and Hispanic people in September. So as you went on, it kind of shrunk down the differences. But there's still significant differences even to the very end. Next. So this is 21st of February. I probably have data from today or yesterday, but I didn't have time to put it on. But the point here is the biggest bar there, and this is right now, were 18 to 29-year-olds. So those are the people that had the most number of cases. But if you look at cumulative hospitalizations in race in the United States, this is cumulative. You'll see that there was a significant difference there. And of course, the brown arrow is African Americans, blacks, and whites. So there was a big difference in hospitalizations in the United States. But remember, blacks are only 13 or 14% of the total population. In Louisiana, they're 35%. Next. So this was deaths by race. And again, it should be proportional more or less to the demographics of the area. And, depends on your area. Region 5 is right in the middle. Then you have region 6 next to it. And this is cumulative. So this is what's happening right now. But remember, we had a shift between a predominantly black pandemic to a predominantly white pandemic. Next. So this is deaths by month and race. And blacks had the higher death rates in the first and second surge, but then whites caught up and exceeded it. So why did that happen? Anyway, I might answer some of those questions, so don't shout out quite yet. Next. So this is, we already looked at this a little bit. This is deaths by age group. And of course, the 70 and above, they got it. And why? Because they had a lot of problems. And the older you get, the more likely you are to die. And that group really got it, even despite the fact that they're the most highly vaccinated group in the state. Next. Now. So a lot of people looked at all this and said, so what happened here? And this was mostly true in the beginning, and it shifted in the middle. But they attributed a lot of this differential to the fact that the African Americans, the blacks, had more pre-existing conditions, because it's always related to your pre-existing health, limited access to health care, which depends on the region, multi-generational housing, dense housing, and more likely to work in frontline industries without health insurance, without paid sick leave, without the ability to work at home. So those are all hypotheses on why this happened. And we'll talk a little bit about all of these a little later. Next. Oops, are we moving? Not moving. There we go. So, if you take the whole deal, this is the whole United States, 13%, blacks are 13% of the population, not 35%, a third as in Louisiana. But they were twice as likely to die from the virus. This is national statistics. 25% of COVID case deaths, 5 times more likely to be infected with the virus than white people. This was mostly done in the beginning because it shifted. Next. What's it asking here? My proxy setting, I don't know what that is. Okay, so vaccinations, I'll talk briefly about that because I'm going to run out of time here. Next. So we're in central Louisiana. I know some of you are some other places, but we, despite all of our efforts, have only managed to do 43% vaccination in this region. So this has been an uphill slog. And some of the down south there are 64 or 54, I guess, 64 in New Orleans and Baton Rouge. They have a lot different resources and different populations and different deals. But we're highly rural, very poor, and very poor low education level. Next. And it varied tremendously from parish to parish. So you can see that it went from 48 to the highest in Rapides down to Grant with 32. Now Vernon's really special. Military population jumps up to 50. So it was really a different scene altogether. But remember, the military got mandated to take the vaccine. The civilian population did not. Next. And this, I assume Lee is noting all of his slides up there. So vaccine by age group, that's kind of hard to see, but there's the biggest chunks are in the older groups. And if you go by race, it's still 60%. So that if you take all the vaccines by race and divide them, it's not very different from the general population. So you have a 30-60 deal. So by a statewide basis, it's kind of not so bad. Next. And as the population, this is just another way of looking at the same thing, almost 49% blacks vaccinated, a little less white people, 47. Next. And this is what happened with the rates of vaccination over this whole time period. African Americans lagged behind in their rates. Rates are, per population. And then something happened. So after November 2020, those lines crossed, and you had a higher level of vaccination in black populations than in white populations. And that was a shift that occurred at a specific time. So, why did this all happen? Next. So this is your unvaccinated by race and, vaccination status by race and fully vaccinated versus unvaccinated, again, 48.9 and 46. Next. So when you look at all the vaccinations and all the age groups, all in Louisiana, your old people, these are the people who die from this. They're very highly vaccinated. This is 85, 89, I don't know. It's really high now. And as you get younger, the percentage of people, you have more people because there's more people in that age group, and the percentage of people vaccinated drops. Now remember, we saw that those are the same people, the younger age group, that had the most cases, but they're also among the least vaccinated. Next. So why were people not getting vaccinated? Who was getting vaccinated and who was not? So somebody in our health department looked at all this, and this is kind of a midpoint. And the people who said, I want to get vaccinated were Democrat. Now, remember, it's a disclaimer. When there's political stuff that comes up here, don't jump all over me. This is just like sociology, okay? Black Democratic reasons 1 and 2. And remember, reasons 1 and 2 are highly populated, and they have higher percentage of African Americans than others, especially region 1. So who was hesitant at that time? White women, moderate, younger women. All these fertility fears and all this stuff that was going on. And who said, generally, white men, conservative, and lower education level. Next. So if you look in the whole United States, this trend was exactly the same. It's just that Louisiana looks a little different than the rest of the United States. So these are already received at least 1 dose. You can't read all the stuff on the side. It's very small. But I picked out a few that you could certainly relate to. If you were Democratic, it was 90%. If you were white or black, it was 70 to 71%. So it was about not that far apart. And if you went down to Republicans, then it was dropped down to 60%. So there was this enormous difference based on your political, sociological beliefs, whatever. So the people who were most likely to get vaccinated were educated, higher earners. Next. I got 2 minutes. So who's actually concerned about all this? So it turns out that if you polled black people, white people, the black adults were 56% of them were very concerned about the pandemic. If you were a white adult, 37%. So there was already a big difference in concern. Next.
Okay. You still
Saw this already. I won't,
see the
go
door.
on with that one.
Go a little bit to
Next.
the right.
Please mute your mics.
Please mute your mics.
Somebody's talking. Claire, maybe. Next. So what were the problems? So if you were an adult Black adult, you had 65% of people said their financial situation was fair or poor. And the pandemic, so there were these big, you can see the racial distributions across the bottom, and among the highest, these are compared, the blue thing was 2020, between February and May, so not that long difference. The anxiety about financial situation increased, and this was all during the pandemic. Next. Who was likely to lose their job, at least in the beginning? 53% of Blacks 18 to 48 experienced loss of work, been fired, or furloughed. So the differential economic impact of COVID was enormous. Next. And job security was indirectly related to educational level. The lower the education, the greater the job insecurity, of course. So you can't read all those nice statistics on the side, but there's always this big spread between educated, the level of education. Next. Debt and that sort of things, that Black Americans were more likely to have taken out the debt for household expenses. Blacks were more likely to use credit cards, loans, or borrowed money. And everybody knows where the payday loans are located and all that stuff. And more likely in households or some pandemic-related unemployment. Next. And if you looked at just unemployment, there was a huge difference, proportional to the population. Next. So more Blacks than whites said someone in their household lost a job or took a pay cut because of COVID. So white people were infected too. 38% is nothing, but 44%. And 70% of Blacks said they did not have a rainy day fund versus 47% of whites. So there was no economic buffer at all. So you put a stress on this and it causes lots of problems. Next. Household insecurity, we talked a little bit about this, where people live and affected that. And there's also more likely to be multi-generational housing or substandard housing. Next. You go down to the bottom, it's Blacks who live in neighborhoods with a percentage of multi-generational housing. Now this is like a national statistic. This is probably greater in Louisiana. Next. Food insecurity. So, people had 11% were more likely than whites to report not enough food. Next. And then you put them all together, housing insecurity, food insecurity, financial insecurity, or fired and unemployed. And every single time, the little pink dot are Blacks opposed to the other races, although Latinos had a lot of problems too. So this ran across the board and affected anyone who was, African American in general. Not meaning they're very wealthy African Americans and all that, but this affected people disproportionately. Next. Number of murders went up, and on the right you'll see Baton Rouge area homicides that went up, and Baton Rouge, the rest of the United States. So this is a national phenomena, but it also affects Louisiana as well. Next. I'm not even going to dwell on it because Dr. Mendoza will talk about this. It's been a catastrophe for mental health services and drug addiction and the rest. Next. Drug deaths. Next. More Black women than white women were concerned about their reproductive health care during COVID. Where are they going to get it? How are they going to get it? Next. And then educationally, 62% in the middle is access to full-time in-person care. And this varied, this is national statistics, but there was a big difference between white and Black populations. Next. And you put people out of school and you say, you go home and you work on your computer. Look at the areas that have no broadband access in Louisiana. Less than 15 are those dark things. That's the whole nation. go up to Louisiana, and then you swing down to those things that have where we have bad health outcomes. I mean, all of this is mixed up. It's all together. And every time you put a stress and strain on a system like a pandemic, it is going to differentially affect people who are already having problems. Next. And then the big white squares there were death rates in groups, and it was related to education. So it's the least educated is the yellow square, and then it goes down. So this affected people who had low education levels, low incomes, and Blacks are highly represented in that community. So this has been kind of a catastrophe. Next. Whoops, are we blocked? Mental health has been a train wreck. I'm sure all of my people are here from human services districts, adults with symptoms, you know, I mean, this has just been a train wreck. Next. And I'm not even going to talk about the rest of these because they were all, because I'm out of time, but they were all counties that had voted over 70% Republican versus 70% Democratic on a national level, and the differences in cases and death rates and all that, and it's stunning. So I'm going to stop there and pass it on to, did Christina ever show up? There she is. Okay. All right. So just think of your questions, and we have time at the end. Did anybody find that interesting? Okay. All right. And it was successful, I guess. All right. Next. I think I went 4 minutes over. I'm sorry.
I just got one.
If you need to do technical things and we can put Mendoza, it's up.
Bear with us for just a moment as we transition.
Okay, well then, since we're just sitting here, were there any questions about any of that?
Great presentation, Dr. Holcomb. Just asking, will we have access to your slides? They are great.
I have autosclerosis and can't hear very well, so you have to really scream.
I said, great presentation, Dr. Holcomb. I appreciate it. We're just wondering if we would have access to the slides.
I don't know who did this exactly, but some of it was done by Pew Parent Charitable Trusts and, you know, different folks. So there's some, there are definite databases about that, and a lot of it appeared in the New York Times. So the New York Times would cite the sources; they didn't invent them. But it was really disturbing because
I mean, I've seen the county stuff, but I just don't know how they got the visual level.
well, they had to have extrapolated from the individual level to the county level because, you know, that these were by counties. But, you know, in central Louisiana, every single county was 60% Republican or higher.
Yeah.
Some are up to 85%. So there was a huge difference there. And, but all were 60% or over.
But they weren't correlating so they were just correlating the
Deaths.
geographic data in that county. They weren't actually looking at individual.
No. So what they took was like how these people voted and then what their recorded death rates are. Yeah, case rates and death rates.
Individual voter records.
I don't know how they determined that. I think they determined just by the election result. So do that. I did it for Central Louisiana just to see how people voted. Sorry.
I'm sorry.
Any other questions since we're?
Dr. Holcomb, if you have time for several questions and comments in the chat, I'd love to have a few minutes.
Okay, I will probably we'll do that at the end because it's just, or otherwise we're not going to get through in a timely way.
Dr. Holcomb, they're asking if they can have a copy of your slides. Can we send that out later?
Rither is out the political ones. It's okay with me. I mean, I will provide them for anybody. You just have to notify david.holcomb@la.gov. If you want to have them, I will send them to you. PDF form, because there's too many and it blocks up the thing with the PPX. But remember, you have to use these with some discretion because people don't interpret this stuff in the same way. And you got to be a little bit cagey.
Hello, everyone. My name's Christina Larson. I'm with the Office of Public Health and the STD HIV hepatitis program. Actually, it started last night. I went to put on dress pants for the first time in a year and a button popped off. So I'm in jeans today, adjusting to a life that's kind of coming back to normal. But I am going to talk about how the different populations in Region 6, the Alexandria region, that are impacted by HIV, syphilis, and Hep C. Next slide. So HIV in Louisiana. So in 2019, Louisiana ranked 4th in the nation for HIV diagnoses. And the largest proportion of those diagnoses, 70%, were among Black people, which is an overwhelming disparity considering that Black people only make up 32% of the state population. Additionally, 61% of new HIV diagnoses were among gay and bisexual men and who have sex. Next slide. And this is just looking at the trend of HIV diagnosis in Louisiana over time. And you can see that COVID we were on a downward trend. In 2018, that was the first year since Katrina, where we had less than 1,000 new HIV diagnoses in the state. That trend has continued. However, COVID has had a large impact. Thank you. So not as many people are getting tested, and we are seeing, looking at the most recent data for 2021, that we are gonna have more than 1,000 cases of HIV in the state again. So there are people in 2020 who weren't able to access healthcare, they weren't able to get tested, all the good stuff that should be happening that didn't happen because of COVID. And we are gonna start to see those impacts as things start to return to normal, HIV and STDs. Next slide. So the impacts of HIV in Louisiana. It's not showing up. Okay. So from 2019 to 2020, new HIV diagnoses decreased by 19%. But that's not a real decrease. That is just due to differences in testing. Next slide. Oh, there we go. Okay. Additionally, from 2019 to 2020, linkage to care for people who are newly diagnosed with HIV decreased from 76% to 72%. So ideally, when somebody goes in, they get tested for HIV, they find out they're positive, they should be linked to appropriate healthcare within 30 days. It's, if people don't get that follow-up care as soon as possible, they get lost. It takes a while to get them back in HIV. And we really do find that people who are able to get treated have much better health outcomes than people who don't start treatment. And then 65% of people were virally suppressed in 2020, and that's down slightly from 2019. Next slide. So in 2020, Region 6 had the 7th highest number of HIV diagnoses in Louisiana and the 4th highest rate among the 9 public health regions for AIDS diagnoses. Next slide. So new HIV diagnoses. So this slide, you see the trend of new HIV diagnoses versus new AIDS diagnoses. So this is an indication of the AIDS diagnoses is an indication of how well we're doing with getting people in care and making sure that they're appropriately treated for AIDS. So ideally, those number of new AIDS diagnoses should be very minimal. And when people are newly diagnosed, we should be catching it early. We should be getting them in care. They're not progressing to the different things that can happen when you aren't virally suppressed. Next slide. So new diagnoses by race, ethnicity, and transmission category. We see that the largest majority of diagnoses happen in gay and bisexual men, especially those who are Black. Considering the share of the population that they constitute, that's a really glaring disparity. Next slide. So new HIV diagnoses in region 6. So 75% are male, 57% are Black. And then you see that the majority of new diagnoses are in people who are 20 to 29 to 40 to 49. Next slide. And then looking at this by parish. So the largest number of diagnoses occur in Repeat Parish. And then the other parishes in Louisiana are minimally impacted. So this far to the left is Repeat Parish. Next slide. So the HIV care continuum, for those that aren't familiar with this, the slide on the very left is the total number of people who are living with HIV. The next slide is people who are engaged in HIV care. So that's defined as having at least one HIV lab done within a year. The next bar is retained in care. So that's having multiple labs done within a year. And then the virally suppressed. So when looking at these care continuums, we want all the bars to be all the way up. We want people to be accessing HIV care. We want them to be getting labs done, and to make sure that they're virally suppressed and the treatment that they're on is working. In particular interest is having that viral suppression as high as possible, indicating that the virus is controlled in their body and they're more likely to have positive health outcomes. So of people who are engaged in medical care, 86% was virally suppressed. And this is just slightly lower than the state average, which is at 87%. Next slide.
We have a question.
Mhm.
Robert asks, are there cases of perinatal HIV transmission in region 6?
I think I have some slides coming up talking about that. Yeah, next slide. So viral suppression among people living with HIV. So this is just looking at people who we think are living with HIV in region 6, and people who we know are in care. So of people who are in care, we can see that upward trend over time, with 86% of people virally suppressed who are in care. Next slide. The HIV care continuum by race and ethnicity. So we see that white people are more likely to be virally suppressed if they're in care, 90%, versus Black people, where 85% of Black people who are in care are virally suppressed. Next slide. Okay. So kind of shifting gears a little bit. So in 2019, Louisiana ranked 9th in the nation for primary and secondary syphilis rates. We've been averaging about 700 cases a year. That is going up. You can see that in 2021, we had 842 cases of primary and secondary syphilis. And data are not closed out, so it's likely that that number will increase. So that's a pretty concerning increase. Next slide. So primary and secondary syphilis in Alexandria. So we've seen a really large increase, particularly in the Alexandria region for syphilis. So far, we've had 158 cases reported for 2021. That's nearly 5 times the number that was reported in 2017. And especially if you think about, the impact that COVID has had with people delaying testing, delaying going to the healthcare, there's probably more. You can find it. Next slide. So Alexandria has had the highest rate of primary and secondary syphilis of all public health regions in Louisiana. In 2021, the majority of cases were residents of Rapides Parish, followed by Grant Parish, and then Avoyelles. Next slide. Okay, so what do people who are newly diagnosed with primary and secondary syphilis look like? So 64% are male, 54% are white, 37% are Black. And you see that the majority are 20 to 39 years old. Next slide. And then looking at race and ethnicity by sex at birth. For females, we see that 70% are white, 23% are Black, and then Black and 45% are white. Next slide. So syphilis and HIV in pregnancy. So there's been significant increases in early syphilis among women, which will yield in congenital syphilis. So congenital syphilis can be eliminated through routine treatment and testing of all pregnant women. And per Louisiana law, women who are pregnant should be tested at their first prenatal visit, so ideally in their first trimester, and then again in their third trimester. And treatment for syphilis should be initiated at least 30 days before delivery. So congenital syphilis in Alexandria. So we've seen, similar to the syphilis rates in Alexandria, we've seen a steady increase in congenital syphilis. So there were 19 cases in 2021, and that's more than 4 times those seen in. Next slide. Okay, so congenital syphilis, looking at the women who are giving birth. So 53% of women are white, 42% are Black, and then 58% are 20 to 29 years old, and 21% are 30 to 39. Next slide. So yeah, the big takeaway for syphilis is that there needs to be more testing in Alexandria, especially for pregnant women. I'm trying to remember the numbers for HIV. I don't think there were any recent cases for perinatal transmission of HIV in Alexandria. It's pretty rare that we have those cases in Louisiana. It's usually like 1 or 2 a year, but they do come up. And that is pretty unusual for a state in the United States. Usually the number of HIV transmissions, there's effective treatment to prevent transmission of HIV during birth. That just needs to be noted and that given at the appropriate time. So shifting gears a little bit, HCV in Louisiana. So Louisiana ranks 5th in the nation for liver and bile duct cancers and 3rd for deaths from liver and bile duct cancers. This is something we look at because their surveillance and counting hepatitis C is somewhat recent in some states. Louisiana has a longer program, more activity has gone into that, more resources. Some states are just getting their hep C surveillance off the ground, so there's not good national comparison data. Additionally, people who have a history of IV drug use or our current IV drug users are at a high risk for Hep C. So when you think about Hep C, there's kind of two populations we think about: who were likely acquired it, some time ago. They're due to transfusions or drug use, all sorts of reasons from like the 80s, before we had a safe and secure blood supply from Hep C. And before we really knew about the virus, we were able to put prevention measures in place. And then we think about this younger population who is acquiring the virus at a much younger age. And that's primarily through drug use, especially injection drug use. So as we see opioid abuse increase, and we see Hep C rates increase as well, those really go hand in hand. And currently in Louisiana, we have an elimination program for Hep C. So anyone who is enrolled in Medicaid should be able to find a provider, start treatment for Hep C, and access that care for free. So we know for people who are currently enrolled in Medicaid who have Hep C, they've had a positive viral load reported to the state. There's almost 16,000 people who are waiting to be treated. And currently that number in Medicaid is staying pretty flat. So as more people are getting treated, we're testing more. So we need to ramp up the treatment as well as keep on testing. Next slide. So chronic HCV diagnoses in Louisiana for Region 6. So that top bar is Louisiana and the bottom bar is Region 6. And that huge increase you see in 2014, there's a couple of reasons for that. So, that's really due to surveillance getting better and IT infrastructure getting better, as well as the drugs. New drugs became widely available around 2014 to treat Hep C. So a lot of people didn't tolerate it well. It only worked about half the time. So it was like, why test somebody if you're not going to start them on treatment? So this is really, due to probably three main factors: doing a better job testing people, doing a better job collecting those lab results, and then also the opioid epidemic kind of driving those numbers up as well. Next slide. So the big takeaway for Region 6 for hepatitis C is that it needs more testing. So 4.9%, so this is from 2020, 4.9% of people living in the Alexandria region who are 18 years or older were screened for Hep C in 2020. Of those screened, 10.2% tested positive. And compare that to the state, where in the state we tested 7.7% of people 18 years and older, and of those 8.2% tested positive. Positivity rates for Hep C in the state. So we need to do more testing here. Next slide. So what do the people look like who are diagnosed with Hep C? So 69% are female, 62% are white, 31% are Black. And then it spans the age range. And I will say, looking at, this isn't included in the slides, but looking at percent positivity, we see that the highest percent positivity are among males. So we need more men tested, as well as American Indian, Alaska Natives, Hispanic and Latinx, and white people. Black people have one of the highest rates of testing for hepatitis C, and one of the lowest percent positivity. Next slide. So this is new diagnoses by parish. That far right bar is Rapides Parish, followed by Grant Parish. So that's where the bulk of people who are getting diagnosed with Hep C are living in Region 6. Next slide. Okay, thank you so much. And yeah, feel free to contact me if you have any questions.
So More testing. Test. Syphilis. All right. So I actually didn't let you introduce yourself, but now we're going on from Hep C to opioids, and this is Dr. Mendoza, who's over the Bureau of Health Informatics and has kindly driven up from New Orleans.
Can I make a request? Change the to speaker view.
Oh, you want to minimize that stuff.
We're gonna minimize it.
Blocks that, when you get to screens there, it gets in the way of the stats. You just
Okay.
have to drive it up. You have his things?
It's coming.
Coming.
All right, so
Well, you can give your introduction and
right. Well, thank you. First of all, thank you for asking me to be here. It's the 11th year, so that's an amazing accomplishment. Okay, great. So as Dr. Holcomb said, I'm Lee Mendoza. I'm the director of the Bureau of Health Informatics. I work with a very talented, dedicated, smart group of people who do things like opioid surveillance for the state. We've been doing that for quite a number of years. We also, since the beginning of COVID, have been involved in the data processing and public reporting for COVID-19 cases, deaths, hospitalizations, and now immunizations. So when Dr. Holcomb asked me to present on opioid data, surveillance, and health disparities during COVID, I figured we had enough information to be able to do this. But as Dr. these things are all mixed up and very intertwined. It's almost as if there was an epidemic that collided with a pandemic. And so we're going to step through some of the data to see how things have turned out. So can you go to the first slide? Thank you. So I'll talk about a historical perspective, the drug epidemic in African-American communities, the involvement of the justice system in some of our current conditions. We'll talk about the impact of COVID-19 on mental health, on treatment. Oh, my internet connection is unstable. And the impact on death. And we'll also talk about Louisiana deaths during the COVID pandemic, and we'll have some data for Region 6 as well. So can we go to the next slide? And one more. Thank you. So the war on drugs started a long time ago. In the late 19th century, opium use and possession was criminalized, certainly in response to an opium epidemic at the time, but it was also used to persecute Chinese Americans and Chinese immigrants at the time. Marijuana was criminalized in the 1930s after Mexican immigration following the Mexican Revolution of 1910. It also coincided with the Great Depression, where there was lots of unemployment and increased poverty. Another driving factor was the use of marijuana by jazz musicians, primarily in New Orleans, but in other cities as well. I like to call out New Orleans as being this. At the time, jazz music was seen as a potential contaminant in American culture. So you know that's code speak for a lot of things. In the early 1980s, inner cities were increasingly impoverished at high unemployment rates. Social programs were decreasing, even school lunch programs were decreasing, and there was very little law enforcement involvement. But proliferated, the more affordable form of powder cocaine, so that these formerly neglected neighborhoods now became targets for violent police enforcement activities. At the time, while almost 2/3 of crack users were white, 84.5% of those convicted for crack possession were African American. 10% were white and 5% were Hispanic. Penalties for crack cocaine distribution were 100 times greater than penalties for powder cocaine distribution. Can we go to the next one? Thank you. So if we look at the justice system and drug of choice, you see this disparity between prison sentencing for those convicted of crack offenses versus those convicted for cocaine offenses. So for example, 28 grams of crack cocaine would get you 5 years, but 500 grams of powdered cocaine would get you 5 years. the 18-to-1 disparity. It was much worse before the Fair Sentencing Act of 2010, where that disparity was 100-to-1. And if we look at who was convicted crack cocaine offenses, you see that African Americans made up 79% of those convicted for crack offenses, while 28% of those convicted for cocaine, powdered cocaine offenses were white. Which brings us to the lifetime likelihood of imprisonment, right? If we look at all men, the lifetime likelihood of imprisonment is 1 in 9. I'm sorry, for all men, it's 1 in 9. For white men, it's 1 in 17, but for African American men, it's 1 in 3. And for Latino men, it's 1 in 6. For all women, lifetime likelihood of imprisonment is 1 in 56, compared to 1 in 111 for white women and 1 in 18 for Black women. Latino women, 35. So 3 decades ago, when opioids and crack cocaine were devastating African American communities, the national response was an escalation of the war on drugs. This resulted in widespread incarceration of people who use drugs and disrupted primarily African American families. In 2017, though Black Americans represented just 12% of the US population, they made up 1/3 of the incarcerated population. And in 2012, they accounted for 38% of those in prison and 39% of the population incarcerated for drug-related offenses. We go to the next. That carries through even to today. So today, the African-American population of the United States is at about 13.4%, yet they make up 38.4% of the imprisoned population. We go to the next. Now, even when you are in prison, we see that drug treatment programs have been decreasing over the years. We see that for residential drug treatment, for non-residential drug treatment, and for community treatment. Year after year, from 2019 to now, we've seen decreases in participation. The only increase is in drug education, and I'm not quite sure what that means. We'll have to dig a little bit deeper into that. Thank you. So every year, 650,000 Americans return to their communities after being incarcerated. And sadly, about half of them will return to prison in just a few years. There are so many barriers to success. I'm sorry, was that a question? Or somebody sneezed? There are so many barriers to success once someone has been incarcerated. It's more difficult to find a job. It's more difficult to get a loan. It's more difficult to get health care. It's more difficult to have a steady supply of food. What we see is that everything we consider as a social determinant of health is worse for people who have been incarcerated. So today, the drug epidemic is framed as an urgent public health issue, right? That substance use disorders and addiction are now viewed as a health condition and can be treated, right, with the availability and appropriate services and supports. Meanwhile, people who have been convicted of nonviolent drug offenses are still at a distinct disadvantage. We'll switch over to COVID-19 and its effects on substance use in the US. I covered all that, like you said, we sign up to talk about one thing and might end up talking about another. I go through this to really set the stage so we can see what is the impact of disadvantaging a group of people on an already stressed system. And once we start applying COVID-19 Audio check. Can everyone hear me? Okay. Sorry about that. Okay, so can we go to the next? Thank you. Thank you, Mr. Tamal. All right, so other researchers have done things like comparing urine tests 4 months before the pandemic to 4 months after the pandemic began, looking at drug test positivity. And they found an increase in illicit cocaine, fentanyl, heroin, and methamphetamines from the 4 months before COVID-19 to 4 months after the beginning of the pandemic. Another group in Virginia observed a greater number of non-fatal opioid overdoses in the first 4 months of the COVID-19 pandemic, with Black patients making up a relatively larger portion of overdose visits. So now we're starting to see an inkling that maybe there is some disparity in opioid use disorders, particularly as a consequence of COVID-19. Can we go to the next? So in California, they looked at overdose mortality before and during COVID-19 pandemic in California. So each of these panels represents overdose mortality for a different drug. The red symbols represent Asian Americans, the brown symbols represent African Americans, the light blue symbols are Latinx, and the dark blue symbols are white Californians. So we can see that if we look over time, first of all, overdose mortality is increasing. If we look, for example, at the all drugs panel, we can see that since 2019, we see these increases in overdose mortality, but that increase is larger for African Americans. The symbols represent actual data values, the lines represent projections, and the shaded areas represent 95% confidence intervals. So we see this larger increase in overdose mortality for African Americans for all drugs, for fentanyl, for methamphetamines, for cocaine. And then we see a different shift. We see a higher overdose mortality for white Californians, for benzodiazepines, and for heroin. Can we go to the next? And a group in Philadelphia tried to compare opioid overdoses in different time frames. So they looked this middle blue shaded area is the 3 months just before the pandemic. So this is December of 2019, January of 2020, and February of 2020. Looking at overdoses that present to the emergency room pre-pandemic, and then in the months following the pandemic in April, May, and June of 20. And then compare that to a control group, same time period in the previous year. What we see is that white individuals are represented by the dark symbols, African Americans by the gold symbols, and Hispanic individuals by the light blue symbols. You see that, again, during the pandemic, we see this increase in both fatal overdoses and non-fatal overdoses in Africa. We go to the next slide. So let's see what's happening in Louisiana. We go one more slide, please. Okay, thank you. So we'll be comparing drug overdoses in Louisiana from 2019, 2020, and 2021. The red symbols represent white Louisianans. The blue symbols represent African-American Louisianans. Gold is for all other Louisianans. The numbers indicate the value, so these are the actual counts. And the percentages represent the percent change from the previous year. So we see that from 2019 to 2021. Oh, and before I get any further, I want to make sure that we all understand that the data for 2021 is incomplete. So what you're seeing is best case scenario. As we get additional data and more coroner reports, it's likely that those numbers will go up. Nonetheless, So for white Louisianans from 2019 to 2020, in all overdose deaths. For African Americans, we see this increase is 94%. And for others, we see an increase of 50%. Can we go to the next slide? For opioids, we see overdose deaths increase by 65%. For white Louisianans, increases by 160% from 2019 to 2021. For African American Louisianans, it increases by 38% for other Louisianans. Go to the next. Synthetic opioids, this is fentanyl and fentanyl analogs. Again, we see year over year an increase in deaths. Among white Louisianans, this increase from 2019 to 2021 is 142%. For African American Louisianans, it's 284%. And for others, it's an increase of 240%. And finally, for stimulants, we see among white Louisianans an increase of 106%, 116% for African Americans, and 44% for other. So those numbers are big or small, but if we normalize by population, we can look at rates of death for our groups, and we can use that to compare, region to region, parish to parish. I have to point out that the US Census Bureau made a change in how they classify race in 2020. And so what I've done is I'm using the racial breakdowns for 2019 for each of these years, but changing the total population as determined by the census. So if anyone does racial disparity work and is interested in populations, I urge you to look at the census website so you can take into account the changes that have been made So in terms of rate, death rate, we see that for white Louisianans, there's an increase of 36%, an increase in the rate of death at 36%, right? If the rate was constant, it would be a flat line. It would mean the same number of people are dying every year. But we see an increase of 36%, white Louisianans for all drugs. African American Louisianans, an increase of 95%. So you can mentally draw a line from 2019 to 2021 for white Louisianans and for African American Louisianans, and you see that slope for African American Louisianans is much steeper. So if this trend continues, the death rate for Black Louisianans will exceed that of white Louisianans in the not too distant future. We see death rates among other Louisianans increase by 51%, with this largest increase happening between 2020 and 2021. Again, even though the 2021 data aren't complete. For opioids, we see an increase among the white Louisianans of 66%, from 2019 to 2021. Among African Americans, from 2019 to 2021 of 161%. In others, the increase is 39%. Synthetic opioids, again, fentanyl and fentanyl analogs, we see an increase of 143% for white, 285% for African American, and 243% for others. Again, we've been hearing about fentanyl and synthetic opioids for quite some time. We see in our own data that the danger exists. Stimulants, we see an increase of 107% for white Louisianans, an increase of 117% for African Americans, and an increase of 45%. So let's focus real quick on drug deaths in Region 6. Can we go to the next? Again, so we're looking at the number of drug deaths, and this includes, proxy server, hold on. all drug deaths. So these are counts going from 2019 to 2021. All drug deaths increased by 31%. Opioid drug deaths increased by 121%. Synthetic opioids increased by 180%. And stimulants increased by 104%. Go to the next. All right, so if we look at all drug overdoses, comparing race, we see that for Africans, which is symbolized in blue here, we had an increase of 140% from 2015 to 2020. For white Louisianans, we see an increase of 54%. Sorry, got lost in my notes. We go to the next slide. For opioid overdose deaths, again, you see a steep increase in recent years, looking primarily at 2018, 2019, and 2020. We see an increase both for white Louisianans and African-American Louisianans here in Region 6. Can we go to the next? And again, a steep increase in synthetic opioids deaths going from 2017 to 2020 for white Louisianans, and an increase ever since 2015 for African-American Louisianans. And one more, stimulant overdose deaths. You see here, there are a lot of data points that are suppressed. Report those because we don't want to risk accidentally identifying anyone. So we'll suppress anything between 1 and 5. You see here in Region 6, there aren't many stimulant overdose deaths, but there are some. And of course, one is one too many. See that for African Americans in 2020, there were 16 deaths. For white Louisianans here in Region 6, there are 19 deaths. And go to the next. So why? Why is this? So what we've seen is that we have a justice system that preferentially persecuted certain individuals more than others, right? We have certainly social determinants of health disparities amongst our populations. We had this COVID-19 pandemic in which we had to be socially distant, right? Which meant that for many people, drugs were used in isolation. People's sense of community, right? And we're less likely to be involved in or have social support networks. We go to the next one. Second, pandemic led to significant shifts in treatment practice. So less reliance on in-person treatment, group treatment, more of a shift towards telehealth. And as Dr. Holcomb pointed out, telehealth is not available everywhere. You see where there's broadband, there's certainly disparities in broadband internet access in many of our rural communities, many along the Mississippi Valley. So, right. It's also could be the case that in some jurisdictions, public health resources were diverted away from treatment for opioids and substance use disorder and diverted towards the response of COVID-19, whether it's vaccinations, or testing drives, or whatever else. I'm not sure that that's the case in Louisiana, but I can certainly imagine that that's the case. Like many other things, everything else that we have in our lives suffered a disruption from the supply chain, right? I mean, early on in the pandemic, everyone was running around trying to get toilet paper, right? And even now, you see that there are certain food items that are difficult to find, that before the pandemic, you'd walk into Sam's, Costco, Walmart, anywhere, and it was food aplenty, right? It's a lot less now. Well, those supply chain disruptions also affected the drug supply, both illicit and pharmaceutical. So, which led people to maybe obtaining and using not their drug of choice, but some other drug, or obtaining drugs from not their usual supplier. And so certainly that could have impacted quality and purity of drugs that people were using. And finally, the pandemic likely exacerbated key determinants of opioid use: stress, poverty, joblessness, homelessness, all these over and over again. We keep seeing reported. So we have this storm here. Like I said, we have a pandemic colliding with an epidemic, and it's the people who have the most problematic social determinants of health that are suffering. Now, I don't have the answers about how to fix this. I'm hoping that some of you do, maybe you. But anyway, that's what we have now. Any questions? So I can't walk off without thanking Trinetta Williams, our lead opioid epidemiologist, for supplying much of the data, much of the background, and Teresa Sokol for her feedback and comments and support during this time. So thank you.
That. Okay, so we're kind of on schedule, and it's not overwhelming because the topics are overwhelming, unfortunately. So Ben Nugent Peterson is originally from New Orleans, I guess. Was in China for a while, ended up crash landed in central Louisiana to work with Interfaith. He and his charming wife, Tori, both have theater backgrounds, so that was a necessity for community organizing. And anyway, so I warned him what he was getting into, and he still came here. So anyway.
So no pressure.
No.
Good morning, everyone. And good morning to everyone on Zoom as well. I want to start just by thanking Dr. Holcomb and the entire Office of Public Health team. Y'all have really, truly an unbelievable team, and it's been a pleasure to get to work with y'all for a lot of this past year. I also want to thank my fellow presenters, who I think I was thinking during everybody's talk, if you had any questions about, COVID impacts or STIs or the drug crisis, well, if you don't know, now you know. I mean, I am humbled and grateful to be a part of this discussion with folks like you. So as Dr. Holcomb said, my name is Ben Nugent Peterson. I am an organizer with Central Louisiana Interfaith, based right here in Alexandria, Louisiana, and some surrounding areas as well. We are a broad-based organization, meaning an organization made up of a diverse group of congregations and community-based organizations working in deep relationship with each other to make change in the community. And to be more specific about that kind of change, the kind of change that will result in a common good for folks in the community across a broad and diverse spectrum. So it's not just a tiny group of interested folks here and a tiny group here, hence the word broad-based. We are strictly non-partisan. Broad-based organizations called the Industrial Areas Foundation, which is the oldest and largest of its kind in the United States. And next slide, thank you. Next click. Okay. The topic of my presentation today is power. And although it may be a little different from what we've just heard, if not simply because my PowerPoint skills leave much to be desired, especially compared to my fellow presenters. And it's going to be lighter on data and heavier on ideas. I think maybe it's not so different, because disparities of power in our community directly relate to any and all issues that our communities face, including COVID impacts, STI rates, and drug crises. Because when everyday people are not a part of decision-making processes, which they are so often excluded from, those processes and the decisions that are a result of those processes tend not to result in. Okay, well, can we go back one? Okay, thanks. I want to start by asking a question for everybody in here. Is power a good thing to have? Raise your hand if you think power is a good thing to have. That's a yes. That's most people, yes. Why, Dr. Holcomb? Why is power a good thing to
Well,
have?
it depends. If you invade your neighbor country, it's too much. So capacity for evil is definitely big.
Mm-hmm. Anybody else? Why is power a good thing to have?
It can influence change.
It can influence change. Okay. Raise your hand if you think power is a bad thing to have. Why is power a bad thing to have,
I can do
Katie?
both, so I'm going both ways. here.
Okay, you raise your hand for both. Okay. Anybody else? Power is bad. Why is that?
Yeah.
So I would actually, before I move on, I would encourage everybody to look up the fullness of that quote, because there's a word that often gets left out with corrupt. But still, point well taken. Okay, raise your hand if you think it is neither good nor bad. Power is neither good nor bad. It's indifferent. It's like energy. It flows from one thing to the next. No? No one? Okay. I was in that camp for a while. All right, I'm going to ask that same question at the end if we have time, and I want to see if anything changes. Generally speaking, we tend to think of power, if not as a bad thing, as an intimidating thing, right? It's kind of, it has this sort of like boogeyman energy around it, something that maybe we're afraid of having or using ourselves. Part of what I want to do today is take some of the fear away from that word by offering a simple definition of what power is. And you got a sneak preview. So next click. Power, as we define it, is the capacity to act. If I and a group of people want to get something done and it gets done, well, then we had the power to get it done. And if we want to get something done and it doesn't get done, really wanted it to get done, we didn't have the power to get it done. Next slide. So what I just described by making it a scenario of myself and a group of people exercising power is an important distinction, right? I said we, if we want to get something done. And that distinction is between two kinds of power. One is unilateral power and one is relational power. Power over, unilateral, versus power with, which is relational. The first, unilateral, I would argue, is much more susceptible to corruption, abuse. It is more interested in dominating, right? I want this thing to happen, and therefore it will happen. We're seeing in very real, very disturbing ways today what unilateral power looks like. The other is relational power. This is a kind of power rooted in mutual respect and common interests. It is a far more balanced kind of power. To put it in another context, for those of y'all who are married or in long-term, sweetheart, I want this to get done, therefore it will get done. And we know how that goes. Whether you are the receiver or the giver of that, we know how that goes, right? The other one's different. The other one is we sit down, we talk it out, we work through it. Might be a little bit harder, it might take more time. We have to be vulnerable, we have to admit we made mistakes, we have to forgive. But that's how you build a lasting relationship, right? The first one doesn't last very long. You get caught up in that cycle and that cycle gets old. What happens when we talk through things and work it out together? Okay, next slide. Oh, next slide again. Sorry, thank you. So this is what it looks like when the major areas of our community are in a balance of power. And these are pretty broad general terms, but this is basically what it looks like, right? You've got market power, you've got government power, and you've got civil power, everyday people working in a relation. Everybody has a seat at that table. Now I'm going to put forward that this is an idealized version of what this looks like. And the next slide is what it actually tends to look like in our community. Looks a lot like that. Generally speaking, market power is oversized and uses its unilateral power to have influence over government and everyday people. If power, as we defined it, is the capacity to act, a lot of times the market power dictates the terms of the decisions that get made. Now, again, I'm talking about generalizations. That's not always true, but that tends to be the case in the modern industrialized world. Only a very small handful of people have that kind of market power. And it's left up to the rest of us to deal with the ramifications of the decisions that they make. And I'm not saying that this is necessarily, I'm saying the imbalance is bad, right? I'm not saying that market versus government versus civil. No three of those are better or worse than the other. The key is the balance. And the issue is the imbalance. So the government, but all too often it takes its cue from the market power. And us, little old civil, is that tiny circle. And that circle shrinks year to year these days. Okay, next slide. All right, in the modern world, levels of power tend to look like this. At the top, you've got organized money. And then right below that, you've got representatives of organized money. And then right below that, you have publicly accessible public figures. Next slide. So some examples. Oh, next click. There we go. Some examples of organized money include the oil industry, major retail companies, multinational banks, and multinational corporations. Then underneath that, you've got representatives of organized money. That's foundations, major media companies, some national or mega churches, and major law firms. And then below that, you got publicly accessible public figures. Those are your local elected officials and maybe some heads of local chapters. So a question I have for y'all is, where are you in those three? Where's your family? Where are your friends? Where are most folks that you know in your life in those levels of power? Next slide. Next click. Next click. And keep going. So we tend to be way far down on the fourth rung, unless one of your family members is the heads of one of those things, or you've got a friend who's really well connected. Most of us, the vast majority of everyday people, are down there, which does not mean that we don't have power, by the way. It is when we are isolated and split up from each other that we don't have any power. Next click. However, we make up institutions in our community that do have power. Once again, if these institutions are split up, splintered, siloed, and isolated, that power is rendered fairly connected and working together. That power is able to be exercised, and we get closer to a balance. Next click. And then just a series of clicks. Okay, thank you. And we're talking about, what are these institutions? These are our churches, our mosques, our temples, our local nonprofits, our community groups, our volunteer organizations, our schools. These are things that we used to really invest in, and we tend not to these days. There are real ramifications of this. Next slide. We call these institutions mediating institutions. If you look up the definition of mediate, oh, can you go back? Yeah, no, that's okay. When you look up the definition of mediate, it is to have a relation to two differing persons, groups, or things to settle or reconcile our differences. So when we are able to organize ourselves in a cohesive way, we get closer to bringing our community, next slide, back in balance. Now I want to pause real quick, because I know that's quick. There's lots of general terms. It might seem overly simplistic. The work of organizing ourselves in that way is anything but simplistic. The work of setting aside our real differences enough to build this kind of relational power, which is rooted in trust and mutual respect, is extraordinarily difficult, especially these days. It takes patience. It takes a willingness to listen and be curious, and it takes vulnerability. It also means, not to sound older than my age here, but it does mean this. It means turning off our devices and turning our attention away from screens and back towards each other. Someone asked me recently, a family member asked me, that sounds like really hard work. What's the, what's step rooms together? That is step one. It's just getting folks physically in a physical space. Obviously, during COVID, that was made extraordinarily difficult. But even prior to COVID, it was still really hard to get people to sit down in a space together, look at each other, eye to eye, face to face, and be vulnerable and listen. Listening is tough. We don't take the time to do that often, especially with people we don't know. I'm going to mention one fundamental tool that everybody in here can use after you leave today to build relational power, if you so choose. Next slide. I would consider this to be the foundational, most powerful tool at our disposal, and it's very simple. It's called a relational meeting. A relational meeting is a one-on-one meeting with another person in which you are not just having a chat about the weather or about what you ate that day. You are participating in an active and attentive conversation with another person to build trust and connect with them. You may share a story. Oh, next slide. Thanks. You may share a story from your life that helps shape who you are, and be curious about their stories and what helps shape them. And as you engage in conversation, be attentive to them. Be open to their values and their assumptions. They're going to be different than yours, I promise. And be attentive to their interests and their passions. Don't be afraid to agitate. You know, it can be a little impolite. I mean, not, you know, be sensitive, don't push boundaries, but ask a question that invites someone to reflect on their own story. And if they come back at you and challenge you to reflect on yourself, have the courage to do that too. So Dr. Holcomb mentioned we have my wife and I have a background in theater. And one of my most influential theater teachers, she was an extraordinary woman, is still an extraordinary woman. She used to ask us a question, why do you think people go to the theater? And we all thought, well, it's to escape, it's to see this thing. It's really exciting. Everybody gets together and it's, she said, yeah, it's all that. But why do you really think people go to the theater? Something called I too am that, which is the experience of seeing someone, in theater it's a character on a stage, go through something, tell a story in which you see yourself in their story. So if you do a relational meeting, I would encourage you to seek out the I too am that moment, because there's going to be a bunch of them. But unless you're paying attention, you're going to miss them. And perhaps most importantly, when doing these meetings or these kinds of meetings, ask yourself, how does their story challenge me to think differently about mine? That's a question to take with you and meditate on well after the meeting's over. Okay, like I said, this is the most basic tool you can use, and it's my favorite because anyone can do it. Y'all could schedule a meeting with somebody in here you don't know. And you're gonna be one step closer to building community power. Next slide. Okay, I wanna leave you with this quote, and I chose this because we tend to do ourselves a tremendous disservice when we take the power, and this is all about power, out of words like love and relationships, right? We think of those words as these kind of, I don't know, flowery terms. We get caught up in the romance of it all. And don't get me wrong, that's great too. But there is profound strength in words like love. And we need to reclaim that strength. And Martin Luther King said it best. He laid out the fact that power and love are not opposites, but rather two sides of the same coin, both requiring the other. King said, power at its best is love implementing the demands of justice. And justice at its best is power correcting everything that stands against love. So with that, I will ask the question again. How many people in this room think that power is a good thing to have? Raise your hand. But right off the top, y'all all raised your hand for good. So I don't think any minds were changed. Yeah, right, exactly. Know your audience. Yeah. Any of the folks that said bad at the beginning feel any differently? And be honest, I mean, you feel the same. May I ask why? Okay. Yeah, fair enough. That's it. Thank you all for your time.
We actually kept this on schedule. So I think there were a bunch of questions that came up in the chat box and stuff along the way. So I think now's the opportunity, if people have questions, to ask any or all of us. They gave this that I didn't use. Yes? Yeah, out there somewhere? Hmm.
Yes, I'm here, Dr. Holcomb.
Well, I wish,
I'm here.
do our tech people still here? They came and then they ran away. 'Cause I could
I have my
move this
stuff
around.
loaded.
Okay, so is she,
She is.
how's she getting
I'm
on here?
loaded.
Because I know what it's about. It's about a rural.
You can share your screen now, Liz.
Okay, great.
Liz Leger is a
Share it.
community
I'll-
action person in Boyles Parish specifically, and has been
Very
very instrumental in getting vaccines out and promoting them in Boyles Parish to the point that they are just underneath Rep Needs as far as their percentage vaccination, which is pretty extraordinary because it has a lot of poverty and social issues like everywhere.
So,
Anyway, so this is,
she can't talk.
she can't talk.
She
to us.
can. She can talk. You can't hear her, but she can talk.
Okay,
Yes, I can. I'm unmuted.
okay.
I'm unmuted.
Oh,
I
she
can-
talking?
Yes, she's trying to.
Yes.
You're talking over her. Go ahead, Liz.
Go ahead,
I'm
Liz.
talking. Okay, you want me to go ahead? Okay, well, as Dr. Holcomb said, I'm Liz Leger, and I'm the program coordinator of a nonprofit in Voyles Parish, a small parish, a small rural parish.
I can't hear.
And I'm
Yeah, so we can.
have a great interest in making sure that people in rural parishes have access to vaccines. So thanks to the help of the great staff of the Region 6 office here, some of my favorite people. Okay, someone's gonna have to mute. We're planning a summit on vaccine acquisition. Well, okay, Dr. Holcomb's talking over me.
We have all sorts of.
He's muted. You're not talking.
So, anyway, so.
Yeah, okay, I'm gonna go ahead. Okay, so we're planning a CENLA summit on vaccine acquisition in rural parishes. It's gonna be March 15th at the Paragon Casino Resort in Marksville in the Hall of Chiefs. It's going to be from 10 to 3 p.m. It's going to be hosted by our organization of All Sleeves Up and the Region 6 Public Health Office. It was starting Tuesday, March the 1st. You can register for our summit online at www.ofallsleevesup.org. You can also find the link to register us on our Facebook page of All Sleeves Up. The goal of this meeting is to have rural parishes leave with hope and encouragement, information, ideas, and sources and resources for assistance. Some of the topics we'll be discussing are shots by various COVID metrics, ideas on how to get the wheels turning, agencies to partner with for help, ideas for dealing with vaccine misinformation, and networking with sources and resources, and brainstorming to seek solutions. So we hope that you can come to our lovely little town in Marksville, Louisiana, and join us for a summit on vaccine acquisition in rural parishes. And thank you for giving me this time to do my little commercial. And thanks so much to everyone at LDH and Region 6 for the great help and support they give to rural parishes like mine.
Thank you, Liz.
We're going to be promoting this.
Thank you. He's muted.
We have a few minutes. So who has questions? It struck me when I was listening to Ben that this is very much in the line of Robert Putnam's Bowling Alone in America. And he referred to that as bridging social capital. And it kind of has all that same deal, but that was 2020. 2000. That was published in 2000, so 22 years ago. So it's not a new concept, but it's certainly useful. So questions for STIs? Oh. Okay, so that is for the SHIP. On March 31st, there is our 1-hour state health improvement plan where you're supposed to call in and voice your opinions about all this. It was very curious because they shared the results from the state health assessment. And we had fair participation here, but it was highly weighted to educated Black women. So it just is who answered. And so because we only have 15% college graduates, it's a little bit skewed. Now, their observations were all, they wanted, better job opportunities, better schools, better access to healthcare. And these are themes that we've seen across this every single year that we've done state of health assessments. So the conclusions were not erroneous, but it was a narrow group of folks. And so we're hoping that on the 31st, it's at noon on the March 31st. So Region 6 has all kinds of stuff going on. So we had this, we're gonna have Liz's Rural Health Summit on April 11th or 9th, Jennifer. So whatever the Tuesday is. Was it the 11th? I think it's 11th. April 11th is County Health Rankings, where we discussed the new county health rankings in perspective with the other ones. So we just have all kinds of stuff going on. So questions? Otherwise, I'll dismiss class and you can go out in the rain. No questions? Boy, that's a quiet group. And now I know out on the outside, there was some questions that came through. Were there any that you noticed that we could address? Somebody asked if market forces were so great, was that just a definition of fascism?
Yeah, I did see that.
I mean, if you think about if any of those circles. Well, so what was the question?
Well, they ask if market values, was that the definition of fascism?
If any of those circles become so big that it swallows up the other circles, it doesn't matter what ism you're talking about. That's just it's a completely unilateral totalitarian way of doing things. It doesn't matter if it's the government one, doesn't matter if it's the civic one or the market one. And I think in the image that was presented, those other two still exist. They haven't been entirely eliminated. They're just skewed one way pretty heavily. And so the work is to balance them, which is, look, and like I said, it ain't easy work. It's tough. And like Dr. Holcomb just alluded to, that book came out, Putnam's book came out, in the year 2000. And the themes that he was exploring have really only gotten worse between 2000 and today. But I gotta be honest, I mean, I lose hope. There is so much good work being done, and there's such an energy to build that kind of relational power. It's every single day. I mean, that's the fuel. So yeah, no, I mean, I hear the question, but it's not there yet.
Any other questions, sociological or otherwise? What is it?
There's a message about the state health improvement plan meeting.
Yes.
On March 31st. I didn't know if you wanted to mention that.
Yeah, that's what. This is the link. We're going to be sending out more information about this. This just came out, the link, and so again, part of the state health assessment, and then you have state health improvement plan. The hope is, because they did this 5 years ago, I guess, is that it just doesn't sit on the desk. And what's a little unfortunately disturbing, I know hope springs eternal and all that, and it was the last thing in Pandora's box. Our situation has been with health outcomes between 1860 and 2020, and it's the same places. There's just this should put a fire under every single community activist and every single person, is that, these are ongoing chronic problems that have not been addressed successfully. And so it's the problem for it's a health, health outcomes. And the thing is, you say, oh, well, those are health outcomes, so this must be Office of Public Health that's not doing its job. This is the private sector that's not doing its job, or this is the FQHCs or the hospitals, they're not doing their jobs. Well, 20% of health outcomes are related to medical care. 30% are behavioral issues, which are also largely economically dependent. And 50% are social capital, social determinants of health, which are largely related to income and social status and educational level. 1,000 per capita income and 15% college graduates, and a lot of people who have low social status. That's a formula for poor health outcomes. And so blaming medical care and medical systems for that is very disingenuous, because it's a social problem, because it requires social investment and a will to act. And that's us, sort of, but we're in this room, we're not exactly the power circle. There's some very high power intellectual people in this room, but as far as running the state, I don't think we're right there yet. Anyway, so that was a little soapbox stuff. Question? You have to really scream.
I wanted to know, do you have any data as far as the use of monoclonal antibodies by race?
Oh, monoclonal antibodies. Okay. Well, I established 2 sites here. The monoclonal antibodies, I can't give you like a who got them breakdown. I mean, I think that would be very interesting to get. But when we had the Delta, we had quite a bit of this stuff, and we actually established 2 sites. We established the one at the Coliseum, and then one in Leesville, which was I thought very weird site. They gave like 700 of these things. It was one of the highest distribution centers in the state. But also remember that Vernon Parish was one of the lowest vaccinated too, outside of the military. So a lot of people chose to do that instead of get vaccinated.
Was it more black, white, even?
I can't tell you that, because I don't know how they kept their data. These were contractors. But at a certain point, we shut those down because it got really, got down to this low plateau. And so it started going up again with Omicron. And I said, can we start this up again? Well, the only thing that was working was Sotromavac. I gave a little bit of it to the hospitals and all that. So we never even started that site up again. I suspect someone can give that, get that data. I don't know who's collecting the data, because those were contract services. So, but there was a bunch of people in this area who would prefer to take, get sick and take monoclonal antibodies than take a vaccine. It was just unbelievably weird. But, well, I mean, and our vaccine rates are simply not what there should be. And as far as I can tell, the underlying factor there is fear. There's a fear of something. So there's a fear of the science. There's a fear of polluting your DNA. There's a fear of infertility. There's a fear of impotence. There's a fear of government control. There's a fear of, and those are all emotional responses. And it's very difficult to combat that, because I come by, or Dr. Sokol or Dr. Mendoza come by, and they give all these statistics on how, and it's just like, whoosh, because the opposition's here. It's all in your gut and in their heart. And man, if you figured out how to do that, I want to know.
Dr. Holcomb, the Zoom group wants you to repeat that question for them. They couldn't hear our question.
Oh, the question was from Dr. Porter. It is Dr. Porter under that mask, isn't it? What were the statistics here locally about monoclonal antibody use? So that, and it's been a problem because of availability, at least in the 5th wave. And so at some point, if they were keeping adequate statistics, somebody's going to be able to analyze who got it and what part of the population. I mean, yes.
You want to mention something about our Fresh Works program here?
Fresh Works. Well, why don't you talk about it? You're in behavioral health. We'll have a little behavioral health moment here.
I don't think I need a microphone.
Yes, use your microphone. It doesn't work very well. You have to be right on.
We have a Fresh Works program through one of our local agencies, which provides clean needles for people that are actively using intravenous drugs. So I just wanted to mention that we have that in place here in Rapides Parish. Actually, it's just in the city of Alexandria. So it's a program that is to reduce harm and to stop or slow the spread of HIV and other communicable diseases with intravenous drug use. So I just wanted to mention that.
Are you taking naloxone distribution?
We are.
Yes, and actually we have it at the health units. So there's a bunch of places, this is just very recent too from the state level. So we have it at, so anyone, originally they said, oh, it has to be clients to the health unit, but then after. So we have a representative from class. Do you want to address any of this? But you have to yell because it's hard to hear you.
So the Fresh Works program in Alexandria is headed at our agency called class. So we allow anyone that's enrolled in our program. They are able to gain access to fresh, sterile injection equipment so that they don't have to get or reuse their injection equipment. It does put them at risk for HIV, it puts them at risk for hepatitis C, and there are other pathogens and infections that are greatly increased in likelihood if they share and reuse that equipment. So we give them that access to that fresh equipment, but also we help dispose of all that used equipment. So we work with a biohazardous medical waste disposal company. They come and pick up all of our used supplies that participants bring back. So we can get them, kind of off. And if they're not on the grounds, that the streets and the parks, in the trash cans for sanitation work, stuff, or anyone else who might encounter that use sharp material. So we also do naloxone distribution as sort of one of the core components of what we do at Fresh Works. So any participant that comes and enrolls in the program does get either naloxone or Narcan, whichever they prefer. So we have intramuscular, injectable forms of naloxone. And we also have nasal Narcan that we're able to allow participants as well. So anybody not familiar with that, naloxone or Narcan is an opioid overdose reversal medication. It is FDA approved and all that other good stuff to be fine. So once someone, is identified as an overdose on that, whatever opioid it may be, you can use that opioid overdose reversal medication to infect that overdose and save that person.
On that note, I'm gonna say we have naloxone through our Louisiana State Opioid Response Grant. Claire is the primary for that distribution point, does training. She'll come out and train your group. She'll bring you Narcan. But if you can't reach Claire, you can reach us. Most of you know me, Central Louisiana Human Services District, kitty.win at la.gov. Easy to do. Just let us know and we'll.
If you picked up a resource bag in the front, or if you didn't pick up one.
Oh, that's true too.
Information about Fresh Works is in there, along with other valuable resources here in this community.
Okay, we've reached 11. I would like to thank everybody out there who listened to this out in Zoom land, and especially the people who came up here. I would like to finally acknowledge our media presence, which is Alex Orenchuk, whose family is Ukrainian origin, but from Canada. There he is. Anyway, so I thank everybody, and we'll do this again next year if we're all still alive and haven't retired from OPH. So thank you for joining, and I hope you learned something, and have a great day. Okay, and people.